Hello.
Hello, Dr. Ray. How are you?
I'm good.
Welcome.
So, is it working?
Yes, it is working well. I've seen your presentation and yeah, you've done well.
Yeah. So, where are you now?
I'm in Kenya.
All right.
Mindre, Kenya. Yes.
All right. Okay. So, I have already set up the Zoom, I think. So, what I do is just continue with sharing, right?
No, until I allow you to share.
Yeah. All right.
We'll give you time to share. Yeah, just make it ready.
Okay.
Yeah.
I already shared you, right?
Yes, I saw you project it, and yeah, that is the right way. Don't forget to put slideshow.
That's what I'm telling. Yeah.
Yeah, yeah.
All right. So are there any participants getting in?
I guess so. We still have about 6 minutes before we start.
Okay, that's all right.
Yeah, I hope my voice is clear. Am I clear?
Yeah.
Thanks.
That's right. Yeah.
Thank you. Hi,
Ibtisam.
Ibtisam.
Ibtisim.
Hi,
Hi.
how are you today?
Good. So I think we will follow you audio, I think.
Oh, yes, I'll give you every instruction.
All right. Okay.
Yeah. So before we start, we'll remain here.
Okay.
Yes, and after introduction, I'll request you to share. So no worries.
Okay.
Thanks.
All right. Hello? ماشي. እግዚአብሔር ይመስገን. ماشي.
Hello, everyone. Welcome. Welcome to the webinar. We still have about 2 minutes to start. Okay, we shall start. Good afternoon or good evening, everybody, and welcome to today's webinar. Thank you for joining us. My name is Goreti, and I'm from Mindray International Marketing Department. Before we start, I would like to explain the following ground rules. That it is unfortunate that I will not have privilege to listen to your voices. However, I request that you post all your comments or questions in the chat box, which is located at the bottom right-hand side of your screen. I hope you see it. And for the above reason, all your microphones shall remain muted throughout this webinar. And this includes during question and answer session, where I shall read out your questions and direct them to the relevant presenter. And finally, please stay on to this webinar to the end, as we shall have a surprise for you. If you leave before the end and you are the lucky one, the luck will be passed to somebody else. So please stay on. Today we have two presenters. The first presenter, who will also give us the open remarks, is a consultant radiologist and body imaging subspecialist. He is also an associate professor of radiology at Addis Ababa University and the president of Radiological Society of Ethiopia. And this is Dr. Asefa Getachew Kebede. Please, Dr. Asefa, greet the audience. Okay, let me unmute you. Please, Dr. Asefa, unmute yourself.
Yeah, hello.
Okay. Hello to you. Thank you.
Thank you.
Thank you. And our second presenter for today is the Mindray Ultrasound Clinical Manager for Africa. She is a registered sonographer in general imaging, obstetric and gynecology, and vascular imaging. She also has a certification from cardiology department of Georges Pompidou University Hospital in Paris, in France. And this is Miss Ibtisam Kara. Ibtisam, please say hello to participants.
Yeah, thank you, Goreti. Hello, everybody. I'm very honored to be with you today. So see you later. Thank you, Goreti.
Thank you very much, Ibtisam. Thank you. We now go straight to our presentations, and I now welcome Dr. Asefa to give us the open remarks. Thereafter, proceed straight to the keynote presentation, which is on ultrasound in the screening and diagnosis of hepatocellular carcinoma. Dr. Asefa, please, you can now share your presentation and start.
Okay, thank you. Can you see me?
Yes, you can.
All right. So first of all, I would like to welcome all the participant colleagues for joining us on this webinar, which was organized by Radiological Society of Ethiopia and Mindray. And I would like to thank Mindray for being with Radiological Society of Ethiopia and supporting our society in the past, and also currently supporting in all our endeavors. And since this year, this is the second webinar which is been organized with the support of Mindray, and I hope they will continue to do that in the future, because in 3 weeks' time we'll have also the annual CME, which will be conducted virtually because of the COVID, and I hope Mindray would also be helping us and continue to support us in our future CMEs too. So without taking much time, I would like to thank all the participants for joining us, and thank you for Mindray for organizing this webinar. And I have to thank everybody on behalf of the Radiological Society of Ethiopia. And I'd like to thank you all, and I'll continue with my presentation as a professional.
Thank you.
Shall we go on with the presentation?
Yes, please proceed.
Okay, so
it's all yours now.
So thank you for giving me the opportunity also to present this webinar for our society and people all around. And the topic of our presentation will be ultrasound and screening and surveillance of hepatocellular carcinoma. So why do we choose HCC? Because worldwide, HCC is a common problem, medical problem, the fifth most common malignancy in the globally, and the second leading cause of cancer death. So because of the epidemiology and the burden of disease, we thought it would be relevant for us to discuss. And it's also described that it's also a common problem in Sub-Saharan Africa and also in Ethiopia. And the rationale for screening and surveillance of HCC is that regular screening of asymptomatic patients who are at risk of HCC may detect tumor at an early stage when it is potentially curable. So risk factors for HCC are 80% of the cases of HCC develop in patients with cirrhosis. So this is one of our main risk factors which need to be following up. And chronic hepatitis B infection in the absence of cirrhosis. These are really the main risk factors which needs screening and surveillance. And the prognosis of HCC depends on the stage of the disease. So if we detect early, we may patient may benefit from life-prolonging management or potentially curative treatment. Normally, HCC is not symptomatic. So by the time they are symptomatic, it's far advanced. In a symptomatic patient, the median survivor is less than 1 year, and the 5-year survivor is less than 10%. So the best option, best medical option would be screening, which will help us in early detection. So all current guidelines recommend ultrasound as a primary imaging test for surveillance because of its high sensitivity and specificity and a number of other advantages which we'll see subsequently. And neither CT or MRI are advocated for surveillance, except in special circumstances where ultrasound is limited by obesity or other technical factors. What is screening? Screening means a one-time examination test. And whereas surveillance means you do a screening test, serial screening test, it's a longitudinal application of serial screening test. So screening means you do examination on asymptomatic patients at a point in time, and surveillance would be longitudinal examination, serial screening test. So these are the indications that we have already discussed. Cirrhosis of any cause, most common of which is hepatitis Z virus is commonly a risk factor through cirrhosis, whereas hepatitis B virus infection, it can cause HCC de novo without the presence of cirrhosis. So these are really the two common patient populations which require surveillance. So globally, there are two ways of surveillance that has been applied, the biomarkers like alpha-fetoprotein and ultrasound, but now the standard recommended consensus is ultrasound is the main screening method, which has higher diagnostic or value or above alpha-fetoprotein. It can be used together with alpha-fetoprotein, but ultrasound is the main factor. So all guidelines, be it the American Association for Study of Liver Disease, or the European or the Asian Pacific Study for Liver Lung, all recommend ultrasound as a screening and surveillance method. And the recommended interval is 6 months. So patients at high risk of HCC, those with cirrhosis and Hep B virus, they need to be serially examined at 6 months interval. The main goal of this surveillance is to identify HCC at early stage when it's potentially curable. Ultrasound wide, it's commonly widely available. It is superior to the serological test. Studies have shown that the reported sensitivity and specificity, sensitivity would be up to 85% and specificity greater than 90%. It also has low cost, widely available, and it can be done repeatedly without any risk, unlike CT or the cost in MRI. So availability, risk, and effectivity make it ultrasound really a good option. The only drawbacks are its performance will be worse in obese patients and in severe nodular cirrhotic livers. And it's also operator dependent. These are the drawbacks. Otherwise, it's a proven imaging methods. So technique, the patient should be NPO for 4 to 6 hours, and it's done with grayscale, and color will also be applied to assess portal vein. Examination being done to cover the whole part of the liver, both left and right lobe, in axial and longitudinal views. And the transducers commonly applied is a curvilinear or curved end or sector. Linear could be applied for targeted areas, but normally linear, because of its high frequency, It may not have the depths, that's the disadvantage, but can be applied to see superficial targeted areas for examination. Image interpretation, once we examine according to the ultrasound lyrides, there are terminologies and reporting mechanisms that should be done. That's what the goal of probably this presentation would be, to introduce you how it has been reported, or what would be the interpretation would be like in the surveillance program in lyrides, liver imaging, reporting, and data system. So lyrides, ultrasound lyrides, unlike CT and MRI, the score or the overall interpretation describes the entire examination, not a specific one lesion or one observation. Whereas CT, MRI, and contrast enhanced ultrasound, they deal with specific lesions. So there are two scores are assigned during after ultrasound examination. The first is lyride category of observations, and the second ultrasound lyride scoring is visualization. In the first part, in ultrasound lyride category of observation, ultrasound 1 will be given for negative study. Ultrasound 2 would be for an observation of subthreshold. We'll see the definition later. And ultrasound 3 will be given for positive test or positive observation. Regarding visualization, which is very important to describe visualization, minimal or no limitation, moderate limitation of visualization, and severe limitation. This should also be described. So ultrasound 1 or negative observation means you have you have no observation. Observation means in other studies we call findings as either nodule or a lesion or a mass lesion. But with lyride, it is recommended to call them as observation, be it parenchymal change or focal parenchymal change or any nodule or mass lesion. We call them observation. So no observation or definitely benign observation. This is called ultrasound 1, and it's called, which is called negative surveillance. So no observation means, for instance, here we have projected to image the first one. As you can see, this is a cirrhotic liver. So this is cirrhosis at risk of HCC. So we are looking for any lesion or observation which is suspicious to be followed. So here you see practically no any focal lesion suspicious like nodule or something. So we call this, there is no observation. Here also you see both sagittal and transaxial section of left lobe of the liver, which has no any observations. The other one is you have observation, but it is and calls that negative test. This is when it is definitely benign. No observation or definitely benign observation will be ultrasound 1 or negative test. So for instance, here, if you find a clear cyst without any suspicious smaller nodule or anything, this is definitely benign. Another study, you can see a cystic lesion. This is definitely benign. Here we do have an ultrasound of a patient. You have a lesion here in a periportal, between the portal and also hepatic veins. You have an echogenic lesion, 3.2 centimeter in diameter. Normally, this is a lesion which is, we cannot tell whether this is benign or malignant. So and the lesion is 3 centimeters, normally it should have been a positive test or ultrasound 3, but this patient has prior examination of MRI. Here you can see of the same patient. There is a triphasic MRI examination, which has peripheral nodular enhancement in arterial phase, and which is filling in the delayed phase. And T2 weighted imaging showed a hyperintense lesion, suggestive of imaging diagnostics of hemangioma. So because this patient has prior examination of hemangioma, even if the lesion is above 10 millimeter and you have observation, this is benign lesion because it is definitely benign. So ultrasound 2 is subthreshold. We call it subthreshold because by definition, it is an observation measuring less than 10 millimeter and not definitely benign at imaging. So if you have a lesion of less than 10 millimeter in high at-risk patient for cirrhosis, for HCC, be it hypoechoic or echogenic, any lesion which is not definitely benign and less than 10 millimeter would be ultrasound 2. And this will be a subthreshold level and it will have its own management implications. So here you have a hypoechoic lesion less than 10 millimeters. So this is a subthreshold examination. Another one with an echogenic nodule. So if it is less than 10 millimeters, we'll see the management category would continue to study it in 3 to 6 months interval follow-up. So you shorten the duration of interval and look for any progress of the lesion. So small observation less than 10 millimeters are common and they are rarely malignant normally. And they will be difficult to characterize on contrast enhanced MRI or contrast enhanced CT or contrast enhanced ultrasound. So the best option would be to follow up in 3 months up to 6 months interval and see if there is any interval growth. If it remains stable for 2 years, it will be recategorized as ultrasound 1 or negative test and will continue the 6 months follow-up like no observation, ultrasound 1 or negative test. If there is interval growth of and becomes more than 10 millimeter, it will be shifted to ultrasound 3 or positive observation, which warrants multi-phased contrast enhanced imaging. So it's another patient. You can see small echogenic nodule. It's 5 millimeters, so it's a subthreshold. So what you do is you continue to follow up in 3 to 6 month interval. So another patient, an echogenic nodule. You see the lesion showed interval growth in the second study. So if it shows interval growth, this will be labeled as ultrasound 3 or positive category, which requires triphasic, multiphasic CT, MRI, or ultrasound, depending on the setup. For us, the best would be to do multiphasic or triphasic CT examination. Ultrasound 3 or positive observations are an examination which one or more observation warrant further imaging. These observations are focal solid observation greater than or equal to 10 millimeter in diameter, which are not previously categorized as definitely benign, or it may be a geographic area of greater than 10 millimeter of parenchymal distortion. So an infiltrative lesion, ill-defined lesion, parenchymal lesion could also be defined as positive observation, or a new thrombus, in portal vein or hepatic vein which was not confirmed as blunt or benign thrombus, also categorized. So what do we do with this? We directly go into a triphasic imaging with ultrasound 3 or positive observation. So this is an example of a patient which has in the right lobe, you have a hypoechoic nodule of 1.4 centimeter in a cirrhotic liver. So triphasic imaging showed arterial enhancement and washout in subsequent phase. So which is diagnostic of HCC. Another patient, as you can see here, it's not really a focal mass lesion, but you see a parenchymal architectural distortion, ill-defined lesion. So this is regional geographic area of parenchymal abnormality, suggestive of an infiltrative lesion, more than 10 millimeters. So this is ultrasound 3, and triphasic imaging showed typical imaging of HCC. This is also another patient. The other study you can see here, we have an ultrasound show a geographic area of ill-defined echogenicity or architectural distortions, especially for an infiltrative lesion, and you have also an adjacent thrombus. So you have also thrombus and also large area of parenchymal lesion, both of which are suggestive of ultrasound 3 or positive observation, which requires triphasic imaging. So you can see you have arterial enhancing liver mass lesion and also arterial enhancing thrombus, which is diagnostic for HCC. So detection during our interval, this is algorithm that we have already discussed in this algorithm. You have a high-risk patient on surveillance. If the patient is not high risk, we don't go into this LIRAC system. So you interpret or you examine or you follow as any other patient. But in cirrhotic patient for surveillance, if it is high risk, if there is any observation, if there is no observation, it will be ultrasound negative, we have said. If there is observation and if it is also definitely benign, we call this ultrasound 1 or negative observation. This we continue to do serial surveillance. We continue the 6 months surveillance progressively. If you have new thrombus, it's going to be ultrasound 3 positive observation. If you have observation less than 10 millimeter, focal observation of 10 millimeter, less than 10 millimeter, it would be ultrasound 2 or subthreshold examination, which requires short interval follow-up of 3 months up to 6 months. We follow that for 2 years. If it remains stable, it goes back to ultrasound 1 negative observation, or if there is interval growth, it goes into ultrasound 3 positive observation. The visualization score is also important. We have to describe the visualization. If the visualization A will be no or minimal limitation. Visualization B is moderate limitation, defined as a study in which limitation may decrease sensitivity for detection. This has to be described because small lesions may be missed in these areas. If there is severe limitation, we need to describe it as visualization 3, and there are 2 ways to do it. If it is avoidable, we have to do it re-preparation. If it is bowel gas or so, we try to examine. If it is, we cannot avoid it, we may need to do other means of examination like CT or MR in the place of that, because maybe missing in severe limitations. That's the importance of visualization. So after doing the positive test, if you have positive test, we have to go into triphasic or multiphasic CT or MR or ultrasound, depending on the availability and the center that we are working. For us, the best would be to go into triphasic CT examination. So we can use a LIRAD system. I advise you to refer the LIRAD 2018 version. You can see the whole all algorithms. I don't go into that, but the main findings which are diagnostic on triphasic imaging is to look for areas of arterial hyperenhancement, non-rim or non-nodular. If it is peripheral nodular, it means something else. Or if it is really smooth thin rim, it's also is not typical for HCC. So arterial hyperenhancement and venous, venous and delayed washout and capsular enhancement. These are really the classic imaging findings which are diagnostic of HCC, which doesn't require tissue diagnosis. This is accepted by all guidelines of the American, the European, and the Asian. So if you find two of these in a high-risk patient, you can make a diagnosis of HCC. Here you have an arterial enhancing lesion in the right lobe, which showed washout in venous phase, portal venous phase, and we have capsular enhancement. This is typical of HCC, and this applies in a high-risk patient, in this patient with a cirrhosis. So in MRI also, the same thing would apply, arterial enhancement and venous phase and delayed washout. And in a hepatobiliary phase, there is no enhancement of the mass lesion. On contrast enhanced ultrasound, the same thing would apply. The technique is that you do examination. Of course, you need to have appropriate ultrasound machine to do that and give contrast gas bubbles, micro bubbles, IV, and watch in all phases. So the principle is all the same. There will be hyperenhancement of if it is HCC in the arterial phase, and you have start to see washout in venous phase, and subsequently in the delayed phase you have washout. The principle is all the same. So it can be applied like others. So this is a summary of the algorithm. Surveillance in high-risk patient. We use ultrasound with the LIRAD algorithm. If you have a positive ultrasound test observation, you go into diagnostic imaging, multiphasic CT, MR, or contrast enhanced ultrasound. And the finding, we look for arterial enhancement and washout. Or you find liver lesion in non-multiphasic CT or MR in high-risk patient. If it is not a triphasic or a multiphasic study, we have to go into, and if you detect a lesion, we have to do a proper triphasic. This is a recommendation of the LIRAD. We have to go into a triphasic examination of CT, MR, and contrast enhanced ultrasound. Or you may need to do the multiphasic CT or MR patient in a selected high-risk patients, which means we have said that if there is also severe difficulty in observation or an obese patient or which is difficult for ultrasound, in such circumstances we may need to do directly with contrast multiphase CT or an MRI in selected, and we follow the CT MR LIRAD diagnostic algorithm. So in summary, ultrasound is a recommended imaging modality for surveillance of HCC, which is done every 6 months. So we continue to do every 6 months, so long as it is ultrasound 1 or negative study, we continue to do surveillance. It's a lifelong. If it is ultrasound 2 or subthreshold observation less than 10 millimeter, we do follow-up surveillance in 3 to 6 months for 2 years. If there is any interval grows in size above 10 millimeter, it will go into ultrasound 3. If it is stable for 2 years, it go back into ultrasound 1 and continue to do 6 months interval follow-up. Ultrasound positive 3 observation, we proceed with multi-phase imaging. And the imaging criteria, the main imaging criteria are arterial hyperenhancement and washout in venous and delayed phase capsular enhancement in high-risk subjects. This would give us a definitive diagnosis of HCC, be it in MR, CT, or ultrasound. And these are the references. I advise you to see the complete LIRAD from LIRAD 2018. And I thank you. If you have any questions, we can discuss later on. Thank you. So we can proceed. I have done.
Yes, doctor. I'm searching Goretti.
I'm here.
Okay.
Thank you very much, Dr. Asefa. I hope you can hear me.
I hear you, yeah.
Thank you very much, Dr. Asefa, for the interesting presentation. It was such a wonderful speech, and there will be many questions after. Please keep an eye in the chat box. Before we proceed to the next presenter, I would like to remind all of us to post questions or comments in the chat box located at the bottom right-hand side of your screen. I hope you can see it. I now call upon our second presenter, Ms. Ibtisam, to give us a brief presentation on advanced radiology ultrasound features and Mindray ultrasound solution. And once more, I welcome you, Ibtisam, to give your presentation. Please share.
Yes, yeah, I already shared. Can you see my screen?
No.
No, okay. Let me restart.
Yes, now it's visible.
Can you see?
Yes.
Okay. This is my first, I removed the slide. Just tell me if it's okay. Can you see now?
Yes, it is. It's okay.
Oh, okay, thank you. Thank you very much. So hello again. Thank you, Goretti, and thank you, Dr. Asefa, for your excellent topic. Today, my topic is about the high-end and advanced ultrasound technology in radiology. And my presentation will cover 3 parts. The first part, it's a Mindray advanced platform. And the second one is Mindray advanced technology. And finally, we will see our Mindray solution. So let's move to the our platform. We have 2 advanced platforms offering a high-end solution in terms of image quality and application, which is the Zsc Platform and the Insight platform. So let's start with the Zsc Platform. And what is it? It's firstly, the ZST has its own powerful processing architecture based on the advanced technology, and secondly, it has also the enhanced channel data processing, such as the totally new innovative processing based on a channel data. And the core 4 pillars are the advanced acoustic acquisition, the dynamic pixel focusing, and the sound speed compensation. And the 4th pillar is the total recall imaging. The first pillar is the advanced acoustic acquisition, and by transmitting and receiving a relatively smaller number of large zones, advanced acoustic acquisition extracts more information from each acquisition 10 times faster than the conventional line-by-line beam forming method. And clearly, conventional ultrasound images is formed line by line, like we can see here, and the final image is depend on the cycle of transmit-receive time. While by using the advanced acoustic acquisition, the image formation is created by capturing a few number of zones, decoupling with the transmit-receive cycle. And the result is creating one frame much faster and more accurate on a temporal resolution, so that for the system there are more time left to do other advanced mixed imaging mode parallelly without compromising the B mode image. We can see here that when we turn on the color Doppler, the B mode still a very high resolution. The second pillar is the dynamic pixel focusing, is improving the uniformity of the image from the near to far field. And without any focus, you can see here in the image, there is no focalization. And also the whole image is focused automatically and processed pixel by pixel. The third pillar, which is the sound speed compensation, is the superposition of different sequences offering the best image adapted according to the patient's echogenicity. This function is available in the touch screen, and with one touch, the system will calculate automatically the best image and also display the speed ultrasound used by the machine, and it's also improving the depth, especially in the far field here. So the fourth pillar is the total recall imaging, which refers to allowing the system to do retrospective processing on channel data and also permit user to modify numerous imaging parameters on stored image in order to optimize clinical information. And the clinical benefits of this pillar has two aspects. One is the coming from channel data, and the other is the stored images. For the first one, it enables the system to do retrospective processing and gives the potential of the offboarding capabilities for extended research in the future. And for the stored images, it's also able to optimize all parameters in the post-treatment and post-scanning. So in order to simplify the ZST contribution in the daily practice, we can see in the conventional imaging, where we have a focus, the image quality is improved according to the adjustment of the focus. But in ZST, we can see that the whole image is uniform with a high resolution from near to far field of view. Now let's move to the second platform, which is the X-Insight platform. And in order to provide a powerful solution for a high efficiency with the precision of the image quality, We further developed also the X-Insights value proposition by 3 components. The first one is the express clarity, which means more clarity with less efforts. The second one is the exceptional intelligence, which means the intelligence through whole exams to get more done much faster. And the last one is the exceeding experience, which means a better design for more comfort with the high efficiency and ergonomy. Here we have our product line using the X-Insight platform. It's from the DC60, DC70, and the 2 model of DC80 X-Insights. Now let's move to the advanced features and the challenges in the daily work in general imaging is the high image quality requested by the doctors and also the powerful and the strong workflow and the easy to use. And the answer will be our platform, of course, and also our different soft in terms of image quality improvement, and also our dedicated application like elastography and also in vascular and contrast imaging, and some soft also for the ergonomy in the daily work. So when it comes to the image quality, which is requested by all the doctors, we have this pretty much good features HD-scope, and the HD-scope is highly used by our end users and appreciated by our end users like magnifying glasses, and it's based on the complete channel data. The HD-scope can make enhancement on such a specific area with the series of algorithms on interest area, like a tumor or mass dedicatedly. If we look at the image here, such a thyroid has a small mass. Here, let me just remove here. It has a small mass inside, but it is not clear and even difficult to differentiate the order and detail on the right image. But here with the HD-scope on, it's much more confident to distinguish the size and the boundary, even the structure and detail inside. So we have also the dehaze, and the dehaze is it can eliminate a noise signal and improve resolution of imaging contrast for better image clarity with a unique combination of gray card, dynamic range, and the gain setting automatically. The high resolution flow, which can offer, it's offering the improved and improving the spatial resolution in a color mode with less noise and aliasing. This is with the Asher flow color, and also it's available with a power function. The glazing flow is considered as a breakthrough in color flow imaging. It's the illumination model to render and process two-dimensional blood flow data to create stereoscopic effects like a 3D effect. It enhances the fluidity in dynamic of two-dimensional blood flow, especially for some micro blood vessel. The second generation needle enhancement technology for easy approach of the needle to the target and improve accuracy during guided procedures, automatic eye needle angle adjustment by degree based on real-time needle tracking. And also this feature is available in both linear and convex probe with a wide application. The smart track is very useful in vascular, and it's based on intelligent vessel monitoring and the tracking. It can automatically optimize the color, power, and the PW spectrum to reduce repetitive and time-consuming steps simplify the vascular examination workflow. So let's move now to our application, and let's see together the elastography. This is very fastly the history of the elastography, and we can see that at the beginning it's the strain elastography which was the most popular, and now actually it's divided to two types of strain elastography and shear wave elastography. In Mindray, we have all different types of elastography. The NTE elastography based on the strain elastography, and the two shear wave elastography, the qualitative and the quantitative one. So the principle of the strain elastography is that the strain is the deformation due to stress, while stress is different under different compression. Since the stress is the same under one manual compression, strain can be used as a qualitative elasticity analysis. So then there are, of course, some limitation of the strain elastography, which are the following. It cannot give us a quantitative analysis. It's operator dependent and let's say less accuracy. Now, if we move to the shear wave, which is now most popular elastography technology used, especially in abdominal approach, the shear wave is a transverse wave. In terms of this, the tissue particle motion is perpendicular to the direction of a wave propagation. As the animation shows, the shear wave propagation direction is parallel from left to right, while the particle motion is in vertical direction, up, down. And actually, when transmitting ultrasound beam to the tissue, beside the waves, it also generates the shear waves which propagate in perpendicular direction at the same time. So once the system is able to detect the shear waves propagation velocity, it can also be, it can give quantitatively analysis the tissue stiffness. And there are two popular shear waves. The first one is the point shear wave, focusing on only one region of interest with the quantification, and 2D shear wave with the both qualitative image and the quantitative image. So let's look at the advantages of our Mindray STE, which can give the high performance shear waves thanks to Zsc Platform, and also a comprehensive elasticity matrix and the index of reliability, which can help and guide the operator during scanning. While the STQ is only quantitative analyzing, as I said, using a small region of interest and giving only a quantification about the different lesions. If we summarize the technical strength of STE, which is mainly used now, especially, as I said, for abdominal through the convex probe, it's in real time 2D shear wave with a much better penetration, not only for a small part, more accurate quantification, and less acoustic power. Now let's move to our vFlow, which is a very, it's a breakthrough in terms of vascular application. And the clinical study indicates that the pathological change of vessel has been affected by the hemodynamics seriously. And the pathological changes are quite common to happen in a vortex, relating with the plaque forming, arteriosclerosis, and intima thickening. Unfortunately, in the traditional color function, and the PW, we have some limitation for a truly hemodynamic and quantitative outputs. Based on the above reasons, Mindray has launched the vFlow, and it's an amazing tool to study hemodynamics in the medium-sized vessels. And as the left image display, the doctor can get almost all answers from such image like flow power, the flow power disruption showed by grayscale flow, the hemodynamics showed by vector flow, and the above two tools are giving more analysis, qualitative analysis. Meanwhile, we have a quantitative and precise analysis tool, including the flow velocity showed by the row color and row length, and the flow direction showed by the row angle. So if we compare between the traditional color flow motion and the vFlow, the scanning approach is totally different. For the traditional one is a line-by-line acquisition versus the plane wave, and also the frame rate is much lower, and it's angle dependent. In a color Doppler, we all know that we need to adjust our angle, but in a vFlow, it's totally angle independent. So it's also roughly display of a blood velocity versus precisely display of a blood velocity, roughly display flow hemodynamic versus precisely display of the hemodynamic in the vessel. So now let's move to the effusion imaging. And the effusion is one of the most popular topics in ultrasound application. And it's also becoming some kind of necessity in a premium end system in radiology departments. Then why we have to use the fusion imaging? Actually, each modality has its own advantages and disadvantages. And ultrasound is a real-time imaging, flexible and no patient radiation, but it has a relatively lower resolution and patient depending. It's easily be affected by bone, gas, etc. While the CT and MRI has a higher spatial resolution and no patient depending, but it's a static image and brings radiation exposures to patients. So fusion imaging takes advantages of each modality, providing you real-time imaging with the accurate navigation for lesion localization. Finally, it can provide more accuracy and reliability for a pathology diagnosis, intervention, procedures, and treatment evaluation. This is exactly the answer from Mindray. It's offering the effusion without respiration, with the respiration compensation. So Mindray is actually a pioneering, innovates and exclusive technology can get rid of the matching distortion caused by the patient respiration, leading to a new level of precise fusion imaging for a pathology diagnosis in interventional procedures and treatment evaluation. And we can see in the image the difference in the rendering image with and without respiration compensation. So let's see now the contrast imaging. And the most important advantage of our contrast imaging is that it's with better sensitivity, with a low mechanical index, and also a very good penetration, excellent uniformity, lower dosage of agents, and a longer duration of perfusion, and superior tissue imaging. Such a case in thyroid here in thyroid adenoma, comparison between the 2D and the contrast image. It's a very high resolution and also strong echo intensity of perfusion. We can see very clear here. especially in a near field and with very clear contrast agent performance. The last application is the real-time antimedia thickness. So in the conventional antimedia measurements, it's totally based in a static 2D image. It detects the interface of the lumen antima and the media adventitia, then measure the distance between them. But the conventional IMT has some limitation. And the resolution, because the resolution is highly relies on the image and monitor resolution, and also in the 2D static image. The IMT measurement is also based on as it's based on the 2D image, it can't reflect the dynamic changes of the vascular wall with each heartbeat. As we know, the blood flow velocity is changing with the cardiac diastole and the systole, and the blood vessels are relaxing and contracting with the cardiac diastole and systole. So the thickness of a blood vessel are changing, but in conventional IMT measurements, it's only based on the static 2D image. So it only reflects the status of this moment. From this case, we can see that in real time, because this measurement, the RIMT is taken in real time scanning, we can measure totally 6 cardiac cycles. Then it will find out the maximum value of each cardiac cycle and the mean value of the 6 maximum values. So compared with the conventional, it's the results of the RIMT is more trustable and reliable. Because of the high accuracy and trustable results, it can improve early diagnosis of cardiovascular disease and improve the effectiveness of pharmacy treatment follow-up. Due to real-time and auto measurement, it can reduce dependence also on the operator and the image quality as well. Finally, let me give you a brief idea about our ultrasound solution. All our product line is able to do, like you can see, it's very large and long, and it's able to do the general basic imaging. And of course, the advanced technology are more available in a high-end system like a Resonance series and the X-Insight platform. But I selected for you 2 models. The first one is the DCN3 with actually, it's our value range product with a wide range of probe, like you can see, and some intelligent feature. And the DC70 X-Insight, which can offer a high resolution image quality with intelligent, soft, and power workflow based on the X-Insight platform. The wide range of probe, like here with the linear probe, high frequency probe with a large footprint or a very smaller one, can provide this pretty much nice image in a small part, and also with elastography also. And also our single crystal convex probe, which can offer to you a high resolution with a very good penetration in deeper parts. So I'm gonna to stop here. Thank you very much for your attention. And if you have any question, please feel free to ask me. Goretti?
Thank you very much, Ibtisam, for the wonderful presentation and very informative. As you have heard, Mindra is one of the one-stop company in ultrasound. It offers a variety of ultrasound solutions depending on your needs. Therefore, it is one-stop company. We now go straight to the question and answer session. And Dr. Asefa, you're very lucky. Only one question for you. And this The participant asked if you can conclude HCC on ultrasound only.
Okay.
And also, the same question asked if we can replace CT scan with contrast enhanced ultrasound imaging. Please go ahead,
Okay,
Dr.
so,
Sefa.
yeah, I do see, I understand that ultrasound could be diagnostic, but it would be diagnostic if it is contrast enhanced ultrasound. Otherwise, a grayscale and Doppler, according to the standard, because what we are talking about is replacing tissue diagnosis. Yeah, we used to do that. We used to say, based on the risk factor and the finding that we see on grayscale and Doppler and so on, we used to suggest most likely HCC, but now we're talking about replacing biopsy. So that requires the hemodynamic nature of the tumor and avoid biopsy. We need to do multiphasic imaging, be it ultrasound, CT, or MRI. So with grayscale and Doppler imaging, we can suggest, but we cannot go ahead and manage, for instance, do surgery or do ablation or any kind of chemotherapy. So for definitive tissue diagnosis, equivalent to that, we need to do the multiphasic imaging, be it ultrasound, contrast enhanced ultrasound, contrast enhanced MR, or triphasic contrast enhanced CT scan. That's required. So if it is contrast enhanced ultrasound, yeah, we can do it. Otherwise, even if it is suggestive, it's not equivalent to tissue diagnosis. That is a standard. But in the limited resources, we used to suggest the diagnosis of HCC, most probably, but it's not equivalent to tissue diagnosis. That's what I'm talking about, the universal global recommendations. That's it. The second question.
I'll read it for you.
Yeah.
You might not see the second question because the person sent it privately.
Yeah.
And it reads.
Yeah.
Yes. Can I read it for you?
Okay, you can read it for me.
Okay. That is from Aman, and it goes, do we consider capsular retraction as an observation and continuation? Can we use LIRADs for those patients who had septomy for HCC for further follow-up?
Yeah,
Did you get me, Dr. Sefa?
Yeah, I do hear. I can also read. Yeah, I can read Aman's question.
Oh.
I don't understand. As a capsular retraction and an observation in cirrhotic liver, observation means point of our interest, according to the recommendation. Point of our interest are which are focuses, lesions, nodules, or masses, which we consider, which are lesions that we are looking for. These are observations. We don't call them, it could be geographic area of suspicious infiltrative lesion, or a nodule, or a mass lesion. So lobularity, capsular retraction, that, you know, it's not described as an observation. Observations are lesions, either geographic lesions, focal, or nodule or a mass lesion, which can be measurable. Yeah, we can do LIRAD also for following segmentectomy, or we keep on, so long as there is there is a risk factor, we keep on screening the patient. So it should apply the same thing, because we treated a focal lesion, it doesn't mean that there won't be any other lesion. So we continue to do the surveillance. That's my impression.
Okay.
I did see one.
There's a third question to you.
Yeah, tell me.
Please go ahead.
What was the third question? Honor BX?
What does...
Yeah, Kono?
The third question is, what does contrast enhanced ultrasound mean? Do we mean we are to administer real contrast to the patient, or the ultrasound itself makes some contrast?
No, we administer contrast. Contrast, these are micro bubbles. And micro bubbles given IV, the same thing.
Okay.
That's how.
The fourth question goes, thank you, Dr. Sefa. There's a fourth question to Ibtisam, which is asking if there's any approved advantage of using shear wave elastography for follow-up of chronic liver disease patients. Ibtisam,
yes,
the question has been addressed to you.
Yes. Thank you for the question. Actually, we have done many cases and the studies in Italy, in Greece, and also in North America. And I can tell you that now the shear wave is more popular in liver, in liver disease, for fibrosis, and we can share with you our study for that, We are pushing doctors to use the shear wave in abdominal application, I hope I answered to the question.
And
I hope I answered to the question,
I think you have. You have a second question on the same elastography, asking this way: does the new upgrade in elastography increase the accuracy of detecting malignancy? Did you get that?
Yes, I get that. Of course, it's helping for detecting malignancy, especially because of the shear wave is a quantitative analysis, especially the STE elastography. Yes, of course, we can detect. Yes.
Thank you. Dr. Sefa, would you like to contribute to this as well?
Not really. I don't have literature on that. So.
All right. So I would also like to add one thing. We've talked about the contrast enhanced ultrasound imaging. As much as we are, this is a new technology in ultrasound field, and it's really helping with the diagnosis of malignant versus benign lesions. But 90% of users of ultrasound are not taking care of the effects of ultrasound. And I saw Ibtisam talk about mechanical index.
Yes.
If you look at all Mindray equipment on the left-hand side of the screen, on the upper part, you'll always see something written MI and TI. Therefore, it's very important for users, doctors, radiologists who are doing interventional studies to take care of the mechanical index, because it is in contrast study that we have much of these effects. The contrast study can cause cavitations. So it's very, very important to keep the mechanical index as low as possible and possibly below 1. Thank you very much. Thank you very much, the two presenters. We now come to a very insightful part of our today's webinar, hosted by Mr. Ted Liu from Mindra International Marketing Department. And this is Lucky Draw. I hope all of us have kept on to the end. Are you a lucky one today? Let us see. Let me welcome Mr. Ted to conduct this session, and all the best to all of us. Thank you.
Okay, thank you. Thank you very much, Groti, and very good presentation from Dr. Asafa and Ms. Ibtisa. And thanks everyone your valuable time. So next we will go to the most exciting section about the lucky draw. So we have, as you see, we have three prizes here, and the first prize, second prize, and the mystery prize. So let's go. Let's start from the second prize firstly. We have two lucky person in this second prize. So for second prize, here we will say I will say start, and Miss Groti will say the stop, and we will welcome the final winner. Okay, Groti, are you ready?
Yeah. Yes, I am.
Okay, so Sean. So let's wait for Sean to prepare. Yes.
Okay.
Okay, Groti, you can say stop anytime.
Stop. Stop.
Okay, so the winner is Muhammad Hamid. So are you there, Muhammad Hamid? If you're there, please type the message in the dialogue or just say something. Muhammad Hamid. Hello? Are you there? So if Muhammad is not here, we will restart the lucky draw. Also same the second prize. So we will start. Start.
Stop.
So Wondi get net. So are you there?
Please type something if
so
you're there, Wondi.
Wondi? Okay, so we may have a summary at the final. And so for the second prize, we have another yes. So for the second prize, we will go choose another the lucky person. So let's start, Sean.
Stop.
Groti. Okay, Solomon. But
no, it skipped. It skipped. It was Solomon.
Yes, it's some blood. Yeah. Sean is fixing.
Okay. So we start again?
No. Let's wait for Sean. He's reopening the yeah. 那2等奖没了哦。So next we will go to the first prize. First prize is one lucky person, and so Ibtisa, are you there, Ibtisa?
Yes, I am.
So for the first prize, I will say the start and you will stop, okay?
Okay, okay.
Okay, thank you. So Sean, start.
Stop.
Amir Saleh. So that's the first prize, the winner. So we will go to the mystery prize, the Huawei mobile phone. So for Huawei mobile phone, I would like to invite Dr. Asafa to say the stop. So are you there, Dr. Asafa?
Yes.
Okay, so let's start. So Sean, please start. Dr. Asafa, you can say stop anytime.
Stop.
So Abdi Dugama. So are you there?
So there are people who are not attending but registered.
Yes, I think the Adi is not online.
So we have to make the draw from the 23.
Yes, yes. So it's a big winning rate.
Yeah. There are 23 people here.
Okay, so. Okay, so wait for Sean. He's do the operation. Okay, so Dr. Asafa, because the Adi is not online, so we have to pick another person online. So we will go again, okay?
Yeah.
So you can say stop anytime.
Stop.
Wow! Wow! Oh, man. That's the destiny.
Wow.
So Dr. Asafa, you pick. Congratulations, Dr. Asafa. Yes, totally random, and I also feel surprised. So
yeah. Congratulations, Dr. Asafa.
Congratulations to you, Dr. Asafa.
Thank you.
So
Wow.
So I think the most exciting part ended. So here I also, at the last, I would like also all the Mindray team also want to thank your valuable time to join the webinar, and also many thanks for the local partner BMY, the big support for the prices, and also the future market promotion. So in the future, if you have any questions about products or about any inquiries, please feel free to contact us and to contact BMY, okay? So I think for the lucky draw section is finished. So I will leave the time to Groti. So Groti.
Thank you very much, Ted. It was such an insightful session. Congratulations to Dr. Asafa for the lucky winner for the day. It must be such a wonderful feeling. And to us who have not been lucky to including me, let's keep watching for the subsequent webinars by Mindray.
Oh, that's
Maybe we shall be next. Yes. Now we come to the end of today's presentations. Thank you very much, Dr. Asafa and Ms. Ibtisen for the wonderful presentations. I believe that they will contribute to strengthening and improving our clinical practice. Thank you, Ted, for keeping this webinar live to the end. For sure, we will need a repeat of your session another day. To the Radiological Society of Ethiopia, thank you very much for your continuous support. Thank you very much for this.
Thank you.
And also thank you, BMY company, led by Mr. Jonas, for the organization of this webinar, and also Mindray team for the commitment towards this.
Yeah.
And to all our participants, I say kudos for your participation to the end and contribution to this webinar. Now I say goodbye and keep safe. Goodbye. See you next time.
Congratulations, Dr. Safa.
I hope we'll have a winning session next time.
Thank you.
Thank you. Thank you. Thank you all.
Thank you.
Thank you.
Bye.
Bye-bye.
Bye.